Welcome to the Brain People Podcast, a show where four mental health experts team up to bring you practical tools for overcoming mental health challenges. The Brain People don't replace your doctor or therapist, but we will give you some extra tools to help you on your journey. So join us as we fight mental illness, one episode at a time. Welcome to the Brain People Podcast. I'm your host, Dr. Daniel Binus, and I'm a psychiatrist. And today I am joined by my co-host,
Jonathan Edens, and I'm a psychiatric PA.
All right, so today we are going to be talking about our friend Sammy. And some of you may or may not know who we're talking about, but stay tuned. It's going to be a really interesting discussion on an interesting molecule that can make a huge difference in your life, especially if you're dealing with a mood disorder. So, Jonathan, why don't we get right into it? Who is our friend Sammy, or some other people might say Sam E, right?
Yeah, so Sam E is a short for S-Adenosyl methionine. It is a naturally occurring compound, biomolecule, sort of found in the body. It's produced and consumed primarily by the liver, but you can also get it as a dietary supplement. And there's very good reason, for why certain people might want to do that. To go into a little bit more depth, it is involved in a number of biochemical reactions. I couldn't quite find an exact number. Some were saying more than 40, others were saying more than 100, but both of those are relatively big numbers. And some of those processes include things like converting this compound called homocysteine to cysteine. Homocysteine we'll talk a little bit more about later, and then from that cysteine, it's then converted into glutathione. And so that's a very important antioxidant. Antioxidants, as many people know, are really good at reducing oxidative stress. Another process that Sammy is involved in is making polyamines, which is involved in cellular healing, growth, and survival. And then the last, just real briefly, but the one that we'll kind of focus on for the next few minutes, is a process called transmethylation. Transmethylation is essentially moving a methyl group, which is a small component of certain molecules that basically helps these processes to communicate with one another. So it can alter what we call gene expression, so alter your DNA and how proteins are synthesized and whatnot. And so for the purpose of SAMe and how it relates to depression and other mental health disorders, that is the mechanism that is the most important for this conversation.
So when we boil that down and we really talk about that transmethylation aspect, of course, like you said, there's definitely different transmethylation that might occur with genes and that sort of thing. But when we talk about, especially related to anxiety, depression, that sort of thing, could this in turn affect the production even of neurotransmitters?
Mm-hmm. Yeah, that's one of the main sort of potential benefits of SAMe is that. Let me back up in a second and just describe maybe as a metaphor what transmethylation actually is. And most of our listeners are going to be familiar with DNA, right? DNA, its role is primarily in part to encode or create the unique language that the body can use to create certain proteins in the body that are used for a variety of different processes. So a methyl donor like SAMe essentially tags certain genes. Right? It puts a sort of a stamp on it saying, okay, body, I'm going to turn this gene on or I'm going to turn it off. And so some of the genes that it actually turns on are the genes that are required for the production of the different neurotransmitters like serotonin, dopamine, acetylcholine, melatonin, so on and so forth. So when it comes to depression, when it comes to anxiety, when it comes to other mental health disorders. That process of having sufficient and well-regulated neurotransmitter synthesis and breakdown is really crucial. To your long-term mental health. And so that's not to say, I don't want to give our listeners the impression that neurotransmitters are everything as it relates to depression, but clearly it is at least a role that for many people is incredibly impactful if it's out of whack.
So basically, if you think about it, it sounds like it kind of turns on or off certain genetic switches. So of course we talk about that as being epigenetics, right?
Yep.
And so with turning on the right switches, then you're going to have sufficient production of some of these neurotransmitters, like you said, this like serotonin, norepinephrine, dopamine, that although it's not everything with depression, it is related to our mental well-being and mental states. And certainly we know that the improper balance in neurotransmitters can create some challenges, right?
Yeah, and what makes SAMe quite exciting is there's a few different reasons, but one, it's been around for a long time, and so as a result, there was pretty extensive interest in SAMe as a potential therapeutic for depression that seems to have died down over the last couple of decades. But there's a lot of research that was being funded in the 70s and 80s and 90s, and we can talk about why that might have been the case. And its safety profile is really good in comparison to a lot of the other medications at the time, and even some of our currently most popular medications as well. It has some unique benefits of that, and a lot of the research actually suggests SAMe to be as effective, and in a couple of cases maybe more effective than a lot of our antidepressants. So when you compare that balance of efficacy mixed with tolerability, it makes a really compelling picture for why SAMe might be something to consider, especially under the care of a provider that is knowledgeable about this topic.
So yeah, so let's talk a little bit about that. I mean, when you think about the fact that it could actually even work as an antidepressant, I mean, in what regard would you say that we should start considering that? I mean, is that just something that everyone should try as a first line when they're depressed, or are there certain caveats? Like, how should we even consider using it?
So before I say any of that, I should probably state the disclaimer that unless we specifically are your medical professionals, we are your patients, and even then, this would be a conversation to have with us in person. This podcast is not necessarily meant to be treatment advice, and so this is meant to be informational. If it's a conversation you would like to take to your current prescriber, then I think it's a great sort of opening discussion and opening dialogue. With that disclaimer out of the way, going back to your question of who it might be considered good for, I think when we look at the studies, there's a compelling case not only for SAMe to be used as a monotherapy, but there's potentially even a more compelling case for SAMe to be used as an adjunctive medication, or excuse me, as an adjunctive therapy with medication. Adjunctive meaning as an add-on, right, to the prescription SSRI or SNRI. And the research where they've done that, where they've combined those two classes, right, SAMe plus a prescription medication, the relative tolerability has been quite good. There are, of course, whenever you add on additional things, there's potentially increased risk, and we can talk about that too. But so all that to say is, if you're looking for the more natural approach, SAMe is one of the best sort of researched, validated, potentially one of the more effective of the natural compounds that are easily available in the U.S. market. Maybe you've tried and failed multiple antidepressants, and you're looking to get a booster, right, so to speak, right? Maybe that antidepressant has been somewhat effective, but you've reached your max dose, or it's causing you some intolerability issues. Then SAMe could be a potential add-on or replacement for the antidepressant.
Tell me a little more about, because you said the most compelling evidence is probably kind of as an add-on. Tell me a little more about that versus like just trying it initially as a monotherapy. I mean, uh, what are some of the research showing monotherapy versus add-on, and why potentially choose one over the other?
Do you mind, before we go to the research, do you mind if we if we talk a little bit more about some of the
Of
mechanism
course. Yeah,
behind
yeah.
SAMe? So, and the reason why I think it is important is because to understand at least somewhat of a simplistic way of viewing how SAMe works in the body is because it's complex, right? It's complicated, and with at least a simple understanding, you might be able to tweak your overall outcome, right, with SAMe supplementation, if you know why there may be sort of explanations for non-response, right? So some of our more avid listeners, or some people that have looked into more natural means of dealing with depression, may be familiar with this gene deficiency called MTHFR. So MTHFR is involved in the conversion of folate, which is it's a nutrient that we should all be getting. Predominantly comes from plant foods. Many people are familiar that pregnant ladies should be taking folic acid, right, as a supplement, right? And so folate is incredibly important for a variety of different things. However, if you have this MTHFR deficiency, you're not converting folate into methylfolate, which is the methylated form. That then gets converted with the process of B12 and zinc into methionine. Methionine then gets converted into SAMe. Right. So some people might do better with, say, an L-methylfolate as a supplement if they have that MTHFR deficiency, versus, say, jumping directly to SAMe. Now, that's not to say they can't be both used in combination. Some people, especially, I know a lot of our listeners might be vegetarian or vegan, and maybe they're not so good about taking their B12, right? And so that B12 is incredibly important in that conversion of L-methylfolate to methionine, which then, as I said before, gets converted into SAMe, right? So there's multiple different things in that process that could be missing. That with proper help from a practitioner, with appropriate lab work, with appropriate history, the weak point could be more easily identified, right? And so hopefully that was relatively understandable to our listeners. If you need to take a step back and maybe listen to that again, hopefully our listeners are not necessarily trying to do this by themselves.
Yeah.
They are doing it with an informed practitioner who can potentially do the blood testing. But even if they can't, right? Sometimes it is just worth trying those different supplements and seeing what might work for them, assuming they're doing so within kind of the recommended range.
Well, and I like what you're saying, because essentially you're saying, look, let's try to, as much as possible, look at what the true root issue is. And even if you can kind of almost bypass the need for the MTHFR in a way, there's still other downsides to, not having sufficient activated folate to use for your body to use. And so, really trying to understand better what deficiencies your body has is ideal, rather than just kind of a shotgun approach. Although, shotgun approach sometimes can work, right? I mean,
sometimes it works amazingly.
Sometimes we just do throw and say, you know what, we're not totally sure. Let's try some L-methylfolate, some SAMe and B12, and kind of give it a whirl.
See what happens.
I mean,
right?
you can do that, but there might be some potential downsides there, especially, if someone starts getting side effects or something. It's like, okay, well, which one did it? And so, yeah.
Well, part of my reason for suggesting that is I don't want to, especially when we're going through the research, I don't want to over promise and sort of under deliver in terms of results.
Yeah.
If you go to any video or blog post that, say, has comments available for it, that's regarding this particular discussion, you'll see a lot of reports of people anecdotally saying that SAMe was wonderful for them, right? And it worked really well. And then you also see cases in which SAMe didn't necessarily work for them. But that's no different than any of the medications that we prescribe, right? And so it just is going to be your mileage may vary, right? Your response is likely going to be different than your peers, potentially. Okay, but that being said, is that as I said before, there's really good, fairly extensive research as far as supplements go on this particular compound.
Okay, so
And for
yeah,
us,
I've been barely able to contain myself. Like, so are we finally going to get to those?
let's talk about some of the research. Okay, there's been over 50 clinical trials for SAMe, specifically for depression. Now, it's also been studied in a few other conditions like osteoarthritis, like fibromyalgia, and it's been positive in those things as well, right? So SAMe, I guess I should add to that list of potential clients or patients where this might be a good option, is if you have comorbid depression with fibromyalgia or arthritis, SAMe could be a really good option for you, right? There's probably a higher likelihood that you'll respond to it, considering the interlinking of those two conditions as they relate to SAMe. But so going back to the clinical trials for depression, about half of those studies were done as SAMe versus placebo. Placebo, for those of our listeners that don't know, basically, sugar pill, essentially not thought to be inert, right? Not supposed to be doing anything. And then the other half of the trials were predominantly SAMe versus some sort of tricyclic amine. Now, tricyclic amines, those are a sort of a previous well-known class of antidepressants. We don't use as often anymore, but some individuals might be familiar with medications like amitriptyline or nortriptyline or imipramine. These are still sometimes used today, for the treatment of depression. But at the time, they were the gold standard, right? In the 70s, 80s, and even early 90s, they were kind of the gold standard for depression. And so a lot of the studies were SAMe versus one of those medications. In the studies, they were either given orally, intramuscularly, or intravenously, most of them being either orally or intravenously. The reason being is that a SAMe breaks down in the stomach acid very quickly. And so a lot of that gets degraded. And so back when the studies were first started, they didn't really have a good form that had an appropriate coating on it to bypass the stomach acid. And so they just gave it via IV. And the dose is there because of the bioavailability of SAMe, even with that enteric coating on the capsules, is still relatively low. And so you could use much lower doses when you gave it IV. And so, I saw some of the studies were as low as 45 milligrams, whereas now, some of the capsules that they're giving are as high as 3,200 milligrams in a day.
That's a lot.
Yeah, it is a lot. And we'll talk about perhaps what optimal dose actually is based on the research. When we look at all of the studies, as I said, the majority of them, probably around 80%-ish, were actually done in the 70s and 70s through the maybe early 90s. And this is just my hunch, but my guess is because of the TCA's relative toxicity at higher doses and concerns of cardiovascular events and other potential side effects, they were looking for an alternative that was comparable in effect, but much safer. But then when the SSRIs, SNRIs came on board and didn't have all of those side effects, they basically stopped studying SAMe for the most part. And there's been only one study that I'm aware of that actually did a head-to-head of a newer SSRI, SNRI versus SAMe, and we'll talk about the results of that study. But that to me was fairly interesting. There was all this interest in SAMe during those 2 decades. It was shown to be clearly, consistently as effective as the TCAs. And I don't know what your stance on this is, but I've seen many psychiatrists suggest that amitriptyline is still probably the most effective prescription antidepressant. And it performed in the couple studies that they did a head-to-head, it performed as well as amitriptyline, which is just bizarre.
Yeah, it is.
It's
right?
bizarre. It's bizarre that it doesn't get that much attention anymore.
Well, I mean, where's the money? Where's the money?
This is true. Where's the money? Most of the study sample size were relatively small. At the low end, I think 15 was the smallest sample size, and then 295 was the largest sample size. Trials were typically done in doses of SAMe between 200 and 1,600 milligrams per day. So usually that was going to be divided into multiple doses, especially as you got higher and higher. With the lowest, as I said before, being 45, but that was IV, and then the highest being 3,200. And those doses have crept up over time. So, initially, as it was mostly IV, it was on the very low end, and then once they started doing the oral versions, it was like 400 to 800, and then it went up to 1200, then 16, then 32, and so it's steadily increased to see if higher doses actually improved outcomes. And the jury's still out on that. Hate to spoil the ending, but more is not necessarily always better. Is what I want to say about dosage wise. Um,
So if you were to say kind of what would be so far from what we see in the literature, what would be, a reasonable dose to kind of start with, and then maybe to even cap at if you're going to try something like this?
it depends on somebody's desire for results, right? Maybe their overall budget, because we'll talk about the expense of SAMe as well. Whether or not they're taking another antidepressant simultaneously, whether or not they're working with a prescriber, right? All of those factors are something to consider. Just your general tolerability for experiencing side effects, particularly digestive distress, because that does tend to be one of the more common ones with SAMe. I'd say 200 to 400 typically is going to be that recommended starting dose per day, and then increasing up to probably 800 to 1600 is usually going to be the range where most people should probably land. But that's all going to depend on your sensitivity, to the side effects, and then how much improvement you're noticing from the supplement, as you increase. If you're not getting any results by 12 to 1600 milligrams, then I don't know, at least from the research, it doesn't necessarily suggest that doubling the dose up to 3200 milligrams is really that much more of an improvement in overall response. So I don't think we necessarily know if 16 versus 3200 is actually the sweet spot for most people. I don't, and my suspicion is that that's probably not the case.
And does it matter if you take it once a day or twice a day at all?
Yeah, it's generally going to be better to be taking it multiple times daily. So either 2 times a day or even 3 times a day.
So when you're
'Cause it
talking
is
about like the 1600, 12 to 1600, that you're talking about the total daily dose, right?
total daily dose, yeah. So if you're taking 1200, then an easy way to dose that would be 400 3 times a day. If you're taking 1600 and you want to keep it a little bit simpler, it might be 800 in the morning, 800 in the evening, roughly 12 hours apart.
So
Um,
So I
yeah,
still want to go back to my original question on the research, because you're saying that probably best to kind of use it as an add-on, but I'm looking at all these trials and it sounds like they were head to head, and so I guess again my question is when I think about the side effects of SAMe, yeah, there's side effects, but generally more better tolerated than other antidepressants in general. I think
yeah.
we could say that pretty safely. Why not try SAMe as a first line agent, so to speak? And if that doesn't work, then yeah, maybe try an antidepressant and then consider augmentation with SAMe if you want to.
Yeah, and I'm not suggesting that it couldn't be an effective monotherapy. Clearly, there's tons of studies to suggest that. Part of that suggestion comes from a more recent meta-analysis that only included a small number of studies, but that was essentially what they were looking at. What they felt were the highest quality studies.
Okay.
They weren't as convinced in the monotherapy benefit as they were in the adjunctive benefit. The adjunctive benefit, the add-on benefit, is very very compelling, and the monotherapy benefit is maybe not quite as compelling. But for those that might be more wanting to go more naturally inclined, right, with their treatment options, wanting to just avoid prescription medications until later on, then SAMe could be a perfectly sufficient, reasonable first line monotherapy agent to try for depression. To be frank, I'd probably, like, if this were my with certain individuals, if it was their first time, say dealing with depression and looking for something, if this was a patient of mine, I probably would, in many cases, suggest that SAMe be tried. Part of that is also due to its relative more rapid onset. So while many of our listeners will likely be aware that antidepressants can take 4 to 8 weeks to really achieve kind of full results. And most of the time, there's really no benefit after 2 weeks. But SAMe, in many cases, has shown improvement in as early as 1 week in many of the studies. And so, so for people that are looking for maybe more rapid results, SAMe could also be a good option. But let's talk a little bit about numbers regarding some of these studies, because I think these will give our listeners just an idea of what the results actually suggest. So we'll start with maybe the not so good study. And this is kind of the one that a lot of people do reference because it is the only study that compared SAMe versus one of the newer antidepressants. And this specifically was escitalopram, which is generic for Lexapro, which has been one of the most commonly used antidepressants, the last couple of decades. And then they also had a placebo group as well. So there were 3 arms to this trial. It was a double-blind, randomized, controlled study. So this is, considered kind of the best that we're going to get. There were 189 participants with depression, and their depression scores were monitored via what's called the HAM-D, which is a depression scale that is very commonly used in research studies. The length was 12 weeks. The dose was 16 to 3,200 milligrams for SAMe. The Lexapro dose was 10 to 20, which is, all normal, right? All of those are very normal. All treatment groups improved by 5 or 6 points, which was a significant difference from baseline. However, there wasn't a significant difference between the groups. At least statistically, there wasn't, which is kind of shocking because you can interpret that in a couple different ways, right? That SAMe and Lexapro weren't any better than placebo, right? So that's one way of interpreting it, right? Or you can interpret it as SAMe is as good as Lexapro. You can interpret it as SAMe and Lexapro are no better than placebo. But many of the sort of critics of this study noted that there is an incredibly high placebo response in this study. I don't know if you noticed that, Dr. Binus, right?
Yeah.
But the placebo response was 30%, which is much higher than most studies that we see for a placebo response. And so the response rates for SAMe was 36. For Lexapro, it was 34, and for placebo, it was 30. Remission rates, however, were a little bit better, in terms of SAMe and Lexapro. Those were both at 28% remission, meaning basically clinically no depression symptoms kind of whatsoever, basically, under the threshold that we would identify. And placebo was 17%. Now, there were follow-up subsamples of this particular study, and the follow-up subsamples actually showed a statistically a clinical statistically significant difference in both response and remission rates. So that's another sort of suggestion for why this study may not have been may have been sort of an outlier if they were going to do additional studies. But one of the follow-up studies, they had 144 of those 189 participants, and they tested their histamine and carnitine levels just to see if there were differences and how that related to their outcome. And the spoiler on that was it didn't matter. Histamine and carnitine didn't seem to have an effect. But when they looked at those individuals, the 144 that chose to participate in this aspect of it, the results were actually quite different. In terms of response, 45% of those taking SAMe had a 50% or more reduction in HAM-D, and 31% for Lexapro and 26% for placebo. And then in terms of remission, it was 34% for SAMe, 23% for Lexapro, and 6% for placebo. So SAMe, at least in this subgroup, was substantially more effective than placebo and moderately more effective than Lexapro.
Well, and to me, that actually mirrors what we saw from the earlier data, which is that essentially, SAMe was pretty much similar head-to-head with TCAs, because we know that TCAs, if it wasn't for all the side effects, we would be using them instead of Lexapro, right? So it makes sense because we would expect that if that data was actually valid, that it would be slightly better than Lexapro's, which is, I think, what this study actually plays out.
Yeah, it's clearly the study needs to be redone. There, as I said, there's been a number of critiques about this particular study and how it was performed. And so, studies are best when they're re-verified, right? When they're done over again with similar like design, right? And to see if they're reproducible. And so we just don't know because this is the only study comparing SAMe versus a newer antidepressant. Now, there was a study done in 2010. This was also randomized and double blind, and this had 73 participants, so a little fewer than the last one, taking an SRI. So that would be an SSRI or SNRI. But those patients had been non-responsive to that medication. So they did a 6-week trial with HAM-D monitoring, and they were given 800 milligrams twice a day, so 1,600 total. Response rate was 36% for SAMe and 17% for placebo. Remission rate was 25%, and then for SAMe, and only 11% for placebo.
Which, I mean, to me, that's actually that's a nice response and remission rate, especially when someone's failed. When they're non-responders, and so that's actually really encouraging.
Yeah, typically, when somebody's tried and failed multiple antidepressants, like we might be reaching for TMS or antipsychotic medications or, adjunctive lithium and thyroid. But SAMe, a natural component you can get, on Amazon, right? Maybe a really good option that increases your likelihood of achieving remission. So another one that was really impactful. Now this one it wasn't double, it wasn't a randomized double-blind controlled trial. It was an open label trial. They didn't have a placebo group, and it was only 33 participants. They took it for eight weeks. After at least two 8-week trials of an alternative antidepressant, and there was a 60% response rate with SAMe and a 36% remission rate. So that particular trial was incredibly encouraging, especially only done at one of the lower doses, being 800 milligrams per day. So yeah, any questions about those? Those are the only.
If that doesn't excite you, I don't know what will.
It definitely excites me because it gives people a unique option that clearly is distinct from SSRIs and SNRIs. Right?
Absolutely.
And so it can be as a monotherapy, can be as an adjunct, and just having more options. We as providers, and I hope you as patients, like having more options because not every therapy works for everybody, and so it's just good to be aware.
Yeah. Before, and I just wanted to ask, before we kind of wrap things up, any other special populations we should consider SAMe with, and then potential side effects that we should consider?
So one of the ways in which SAMe shines is that it's the rates of sexual dysfunction with SAMe are substantially lower than that of the SSRIs and SNRIs. And so, it's kind of a not what's the word I'm looking for? Not dark horse, but it's the thing that we often don't like talking about in terms of the high prevalence rates of that particular issue with the antidepressant class of medications.
It's the skeleton in the closet, right?
It's the skeleton in the closet, yes. And so for many people, it's a very serious issue, particularly if they are, sexually active. I've had many patients that they were married and their depression was, a real problem, but so was their lack of intimacy after starting the medication with their partner. That was a real problem too. And so to have an option that's arguably similar in effect, but that doesn't induce that sexual dysfunction. For many people, that is an easy choice. And there was actually a single randomized controlled trial. This particular study only used men, but when given SAMe, it improved their sexual function. So that was an exciting result. And then SAMe was studied for aggression in schizophrenia, and they were able to show, particularly for those that had a genetic variant of something called COMT, which we're not going to necessarily go into, but it did show that SAMI at 800 milligrams per day for 8 weeks was able to significantly reduce the outcome of aggression in this particular population.
Which is interesting. Now, one thing that I wonder about, though, too, and I'm looking at the study, it says that it was terminated because the study was terminated because of the worsening irritability in two of the subjects that actually received the SAMe, right? So that's one thing that people would really want to be careful of.
Yeah, it's sort of unfortunate when a medication or a supplement is supposed to do one thing and you actually get the opposite result, right? Unfortunately, it does happen. With a number of prescription medications and supplements, some people just respond the opposite, right? It's typically a small percentage, but it is something to be aware of. And so moving on to side effects, for most people that continue with SAMe, side effects do tend to be relatively mild and temporary, right? That's the vast majority of cases. The most common ones being more so digestive distress. So this could be loss of appetite, constipation, nausea, and so on. But SAMe also does tend to be activating for some people, right? And so it can cause insomnia, agitation, anxiety, and for a lot of people, this can be reduced with time, but for some people, that's definitely not the case. And that really sort of suggestive that they're probably not deficient in internal SAMe, and you're getting too much of this particular thing, right? And so not necessarily going to be a good option for you. Other side effects include things like dry mouth, sweating, and dizziness. And then in rare cases, it has been known to induce mania or hypomania. So for those with bipolar disorder, if you want to try SAMe, you definitely need to do this under supervision of a medical provider. It's the general recommendation, with SAMe or anything that is mood lifting, often that a mood stabilizer in conjunction might be a wise idea. There's also the theoretical concern of serotonin syndrome when combining SAMe, especially with other antidepressants. But I wasn't able to find any reported cases in the literature of that, other than one case in which a patient was using clomipramine, which is an old TCA, in combination with SAMe, and they upped the clomipramine, and then she got serotonin syndrome, but the SAMe was kept at the same dose. So more than likely, it's the clomipramine, right? That was the problem versus the SAMe. But that theoretical concern does exist because it can increase serotonin output. And then the last couple of things I'll mention regarding SAMe is. And this is a partial sort of knock on SAMe because it's been one of the resistance points for a lot of my patients to either take SAMe or continue taking SAMe. It does tend to be a little bit more expensive than most of your supplements. So a 400 milligram dose is probably going to range between 50 cents per pill and $1.25 per pill. So for people that are either on a really low income or where their medications, they have really good insurance and their medications are incredibly cheap. For many people, if you're trying to take 1,600 milligrams a day, and that's running you $4 a day, right? You're talking more than $100 a month for a supplement. And so for some people, that's just out of the question. But a lot of them, and I'm not a shill for Jeff Bezos or anything, but a lot of the ones on Amazon are on that lower end of the reference range, and the brands there, especially the well-known brands. I've had many patients that have done well with those. And so those tend to run more like in that 50 to 60 cents per pill. You want to take one that has that enteric-coated tablet. Most of the well-known brands do. And then it's also, most of them are going to be covered in like a sort of a foil wrapping, because you don't want to keep it where it's hot or where there's direct light exposure, because that can degrade the molecule as well.
Well, thank you. And you can see that our friend Sammy is kind of sensitive, so we have to take good care of him, right?
Absolutely. But he's powerful, right? And for many of our listeners, it might be a topic to look further into and to see if it could be a good fit for you.
Yeah. Well, thanks, Jonathan. I hope that for all of you listeners that this was very informative and that you got to know our friend a little better, and that there was some insight and interest, and this might be something that could really help you on your mental health journey, or maybe somebody that you know. So thanks for tuning in, and we look forward to hearing and really hoping that you're going to listen to our podcast here in the near future. Take care. Thanks for listening. If you enjoyed today's episode, please like and subscribe. Your engagement will help us reach more people who need encouragement. To hear more episodes, learn about our other mental health resources, or support us financially, visit thebrainpeoplepodcast.com.